Medurstand-Understanding Medicine.
Professor Aziz Rehman from Medurstand-Understanding Medicine. Today we are going to talk about this condition which could be very serious and usually very painful, and it is called acute pancreatitis. As the name suggests, it's the inflammation of the pancreas. But luckily it is not very common. There are some risk factors, and if we can control those risk factors, maybe we can prevent this serious disease. Serious and also the one which requires a lot of resources, hospitalization and other things. So definition, it's an acute severe inflammation of the pancreas, usually complicated with autodigestion, and this is different than another inflammation because pancreas is equipped with certain enzymes which can auto-digest the pancreas and the neighboring tissues. Normally it doesn't, but in cases of severe pancreatitis, it can cause inflammation in the pancreas and autodigestion, necrosis and ischemia, hemorrhage, superadded infection and toxemia. So there are so many possible components of pancreatitis. It starts with inflammation, but because of the enzymes autodigestion, there is secondary necrosis and hemorrhage. It is also called acute hemorrhagic pancreatitis because hemorrhage is a very regular feature of this condition. Hemorrhage means hemorrhage into the pancreas and the neighboring tissue in the peritoneum. Usually it is acute. It just comes from nowhere. Patient may have some risk factor, but patient may be absolutely asymptomatic, and the first attack may be severe epigastric pain. Most such patients are usually treated in the emergencies as acid peptic disease or biliary colic, but there are certain points which should raise the suspicion of pancreatitis, and that should lead to the appropriate investigation. A timely diagnosis and a timely intervention in the form of management would definitely alter the results favorably. And sometimes it may be acute or chronic. Those patients who suffer from acute pancreatitis, sometimes they go into chronic phase and they have chronic epigastric pain and dyspepsia and indigestion, but occasionally they have an acute attack, and then the diagnosis may be easy because patient is already a known case, and patient would sometimes guide you that he has this condition. But you need to keep a high index of suspicion if somebody presents with severe epigastric pain, a pain which doesn't go. Now let's talk about a little bit of normal hepatobiliary pancreatic system to understand this condition better. You know, liver secretes many substances, many of them into the blood, but some of them into the bile. This bile comes to in the gallbladder, and then after storage and concentration and whenever needed, typically after a meal, this bile, the gallbladder contracts and this bile goes into the duodenum, and this is joined with common pancreatic duct. So common bile duct and common pancreatic duct, this is the common pancreatic duct, both join each other before they enter into the duodenum at ampulla of water. So this is the mechanism. Bile is also released into the duodenum after ingestion of food, and pancreatic secretions are also produced and released into the duodenum only after meal. In the resting state, there may be very little production of pancreatic enzyme and very little production of bile, or very little bile coming to the duodenum. So it comes only when it is needed. There is a system in the body which can sense what kind of food we have ingested. Now we typically take mixed meal which consists of carbohydrates, which consists of fats and proteins. So accordingly the relevant enzymes will be secreted. Pancreas has got two types of function, exocrine function and endocrine function. This is perhaps the only organ in the body which has got two types of endocrine and exocrine function. Exocrine function refers to the production of different enzymes like amylase, lipase, proteases, which are required for digestion. They are produced by the acinar cells and they are secreted into the pancreatic duct, and then ultimately they come into the intestine. And these enzymes are not active. Very important, these enzymes are not active until they come into the duodenum, and they are activated by gastric secretions coming into the duodenum like acid and other, and there is a system of sensing these proteins and other digestive components, and the enzymes are activated. There is actually cascade. One enzyme will activate the other one, and then it will further activate the other one. But this thing happens only in the duodenum. It does not happen in the pancreas. That is why our pancreas is not normally digested by its own enzymes. In fact, in the duodenum also, there is a protective mechanism which prevents intestinal wall from autodigestion. So that very excellent or almost perfect system of prevention is overwhelmed in pancreatitis. So common bile duct and pancreatic duct join in the pancreas before opening into the duodenum. So if there is obstruction, if there is some obstruction in the distal end of the common bile duct, and if there is a stone, for example, and that gets dislodged from the common bile duct and goes to the end of the common bile duct, which is the narrowest part, so invariably it will block both CBD as well as pancreatic duct. So if pancreatic duct is blocked, that actually stimulate the release of enzymes and then activation within the pancreas. That is the main problem which further leads to damage. Pancreatic enzymes, amylase, which is primarily meant for the digestion of carbohydrates, lipase, pancreatic lipase, which is required for the digestion of fats, and chymotrypsin, proteases which consist of chymotrypsin and elastases, they digest proteins. So these are the enzymes. There may be actually more, but these are the main ones. So this is the normal physiology. I repeat, all these enzymes are produced in the pancreas on demand when we eat food consisting of fats and carbs and proteins, and these enzymes are not active and cannot damage pancreas itself or the duodenal wall. Only in the duodenal lumen they get activated and only digest food, nor the tissues themselves. So what is the etiology? It's actually a fairly long list, but there are some common conditions. I think the commonest one is gallbladder disease. People with cholelithiasis, whether or not known, they are particularly prone to develop pancreatitis, because the pathophysiology of pancreatitis is that there is a small stone which passes through the CBD and it causes obstruction. It may just cause temporary obstruction, stimulate the pancreatic cascade, the pancreatitis cascade, and then it might sometimes go to the duodenum, and on imaging you might never find that stone. But the theory says a small stone passes into the CBD, blocks both CBD and pancreatic duct, and that stimulate pancreatitis. So that is the commonest. I think 50% of people would have this gallbladder disease. Some would be already known cases, and the other would be diagnosed first time when they come with pancreatitis. Now, small stone and multiple stones are more likely to cause pancreatitis as compared to solitary big stone. Of course, big stone is unlikely to go to the CBD and cause obstruction. Then alcoholism. Not just taking a little bit of alcohol, but alcoholism and especially alcohol binges. If somebody drinks in large quantities, that can stimulate pancreatitis. So in fact, it may cause subacute or chronic pancreatitis also, but a binge of alcohol in predisposed people may cause severe acute hemorrhagic pancreatitis. Both conditions can coexist. Then some types of hyperlipidemia and some types of hypercalcemia. Now, these two conditions are difficult to assess while patient comes with acute pancreatitis, because there could be secondary change. In pancreatitis, your lipids get altered and your calcium gets altered. So the best way to screen for these two conditions would be when patient has either recovered or patient has not yet developed pancreatitis. Because during pancreatitis, there is actually possibility of developing hypocalcemia. So previously hypercalcemic patient may have normal calcium during an attack because of the hypocalcemic effect of pancreatitis. Similarly, lipids, because lots of fats is digested and they come to the circulation, there could be actually hypertriglyceridemia. So initial value will be changed. Then trauma, any trauma in the abdomen, it could be surgical trauma, it could be endoscopic trauma, or it could be like patient with after ERCP may develop pancreatitis, or patient after sphincterotomy or stent replacement in CBD can develop pancreatitis, or it could be road traffic trauma, things like that. Infection, many infections, they are systemic infection. They could actually affect pancreas also, like measles and mumps and rubella, HIV. They can cause infection of pancreas, but this pancreas inflammation would not present in a typical way of severe pancreatitis, because this will be then part of overall inflammatory or infective state. Drugs, there are some drugs, particularly GLP-1 receptor agonists, maybe DPP-4 inhibitors also. So these drugs can also be responsible for pancreatitis. Now this is very important. In about 40% of the cases, no matter how much investigation you do, you cannot determine the cause of pancreatitis. There are various theories, and one theory is that there may be actually microlithiasis. These patients may have thick bile, or they may have very small crystals of bile which temporarily obstruct the common bile duct, and you can never determine the presence of these crystals or small gravels, so they are labeled as idiopathic. In up to 40%, you are actually unable to pinpoint the cause. So in them, we can't really do anything to prevent subsequent attacks. Now, pathogenesis. First of all, as I said, the first triggering factor is duct obstruction due to a stone which is passed from the gallbladder, usually a small stone which obstructs the distal end of the common bile duct. Another mechanism could be SNR damage, that is like patient who develop pancreatitis after an alcoholic binge or after certain drugs. So either of the two are actually the starting point, and it leads to activation of all these enzymes. Normally lipase doesn't digest the fat of pancreas, and chymotrypsin does not digest the protein of pancreas, and amylase doesn't digest the glycoprotein of pancreas. But when they are activated, they start digesting the pancreatic tissue, and when they are activated, they are also spilled into the pancreatic tissue and outside the neighboring structure like the omentum and the intestine, the peritoneum, all they are involved. And there's intense inflammation. This, like, I think it is called a retroperitoneal burn. It is literally like that. So much inflammation. It is like an explosion of a bomb inside the abdomen. So it's intense inflammation and secondary necrosis. Necrosis because of the autodigestion by these enzymes. And this could lead to, there is compression, inflammation, and this would lead to ischemia because blood vessels are damaged, and blood vessels also are compressed with the swollen pancreas, and there may be secondary hemorrhage staying within the pancreas or going into the peritoneum, also sometimes leading to seepage into the tissues like abdominal wall and appearing as certain signs, which I'm going to show you in the subsequent slide. There could be local complication and systemic complication. Very serious. This disease, pancreatitis, can literally become very serious. So whenever somebody comes with pancreatitis, we very carefully evaluate and see if the patient is likely to go into serious phase. Those patients who have severe pancreatitis must be hospitalized and must be provided with the best possible care to prevent their to prevent death. Presentation, most important symptom, or at least the commonest symptom or the main clue to the diagnosis is epigastric pain. There are many causes of epigastric pain, many common causes like acid peptic disease, biliary colics, reflux. So these conditions can cause epigastric pain. Even ischemic heart disease can present with epigastric pain. But pain of pancreatitis has got some unique feature. It is usually sudden, and of course it starts at any time, but over the next few minutes to hours it increases in intensity, usually very severe, usually unbearable, non-abating. Pain may be constant dull ache, and it is making patient very restless, and patient is usually changing his position, sometimes taking right side, left side, sit-ups, and lie down to find a position where that patient feels some comfort. So it's very severe pain, continuous pain, very agonizing, and it may radiate to the back, or sometimes patient may feel pain in the back, and patients sometimes say it is as if some nail is going right from my stomach into the back. So I think that kind of feeling. So my suggestion is, if you have a person with epigastric pain which is severe and continuous, I think you must suspect pancreatitis. You must do some tests to rule out pancreatitis. Even if patient says that he's got this acidity problem, you must do appropriate tests to rule out pancreatitis, because early diagnosis can translate into better prognosis. So after pain, there may be severe anorexia, there may be nausea and actual vomiting. And after the food is vomited out, patient might be just throwing up the normal stomach secretion. Abdominal distension may be there because of maybe some paralytic ileus. That is typically a feature. You examine the patient and you will see abdominal distension, or patient will say as if the air, the food is stuck, something is stuck in the abdomen. There may be fever. Fever could represent pancreatitis itself, or sometimes superadded infection. Fever is also a fairly irregular feature. Of course, when fever is a predominant symptom, then you need to consider other possibilities also, like cholecystitis or liver abscess or hepatitis. Jaundice, liver function tests, they get deranged in almost all cases, but in some cases there may be jaundice, because once pancreatic duct gets obstructed, then biliary secretion will be held back and patient may develop jaundice, obstructive jaundice. So I think symptoms are fairly suggestive. If you keep a high index of suspicion, you should be able to suspect pancreatitis in almost all cases. Pancreatitis then should not come as a surprise to you if you take the case methodically and you listen to the patient carefully. On physical examination, patient will look in lot of pain and agony. You can tell from his facial expression and his movements. He's constantly moving that he is in a lot of pain. And then if you examine abdomen, you might find it little distended, and on percussion you might find little tympanic, indicating gas trapped in the intestine, and altered bowel movements. Of course, not in all cases, but in some cases, because of paralytic ileus, because of the involvement of the intestine, the movement of intestine is reduced, and you may find paralytic ileus. Occasionally, there may be a phase where the intestinal sound may be actually increased. Feeling of mass or fullness. When you examine, I think you need little experience to pick up this finding. You will not find a very distinct mass. When you examine the patient and then you examine the epigastric part, you feel that there is little mass. There's not a normal feeling, but you will have the feeling as if there is some mass-like thing, and there will be tenderness. So feeling of mass and presence of tenderness would be a very suggestive. So these are some of the signs. Of course, there may be some systemic signs, non-specific. These patients may have hypotension, they may have tachycardia, they may have tachypnea, they may have fever. All these things are to be noted, but these are the one I'm listed here, the important physical findings related to the pancreatitis. These are some of the signs which are described in literature, and frankly speaking, they are not very common, perhaps because we can now diagnose pancreatitis early and we can prevent disease to progress to that level when these signs they do develop. This is Cullen sign, and this is, you can see the umbilicus, a reddish brownish pigmentary change around umbilicus is called Cullen sign. It indicates the seepage of blood into the abdominal wall. You know, hemorrhage is a common feature of pancreatitis, and that blood can come into the abdominal wall and produce this sign. And this is another sign similar or maybe slightly different color on the flanks. You see this, the grayish, the brownish color, and the flanks is called gray Turner sign. These are the signs described by these scientists. Now this is again blood and maybe some pancreatic enzyme also getting into the abdominal wall and causing some local digestion of the tissues and making some color changes. Now, investigations are needed. Of course, you would be able to suspect pancreatitis in majority, I would say. If you're reasonably trained, I think you would be able to suspect pancreatitis in majority. But of course, laboratory tests are needed to finally confirm the diagnosis and to also assess its gravity and the etiology. Amylase is done, but amylase is secreted in large quantities in pancreatitis. But you know, in pancreatitis, after certain times there is stoppage of further production of enzymes. That is a kind of self-protection. Whatever amylase is produced, it gets excreted within sometime 24 hours. So if you happen to see a patient within 24 hours, you would see that the amylase is elevated. Be aware of a condition called macroamylasemia. So patient could have elevated amylase when he does not have pancreatitis. In that person, genetically amylase is large protein and that doesn't get excreted by the kidney. So this patient may actually have some other cause of abdominal pain and amylase may be elevated because they have macroamylasemia. But generally, if you do amylase within 24 hours, we expect it to be elevated. Sometimes moderately elevated, like 400, 500, sometimes even higher value. Lipase is more specific. Amylase is more sensitive and lipase is more specific. These days we do both. So by more specific means, if lipase is elevated, it's more likely that patient definitely has pancreatitis. Amylase is likely to be, if amylase is negative, then you can reconsider your diagnosis of pancreatitis. So both are done usually in a single go. Then urinary amylase, I don't think we do it anymore, but in the literature it is mentioned that there may be a situation where serum amylase has returned to normal, but urinary amylase may still be elevated. We don't do this test anymore because we have alternate methods of establishing the diagnosis of pancreatitis. Blood glucose may go down or may go up. So this is also depends on the condition. CBC, of course, CBC is the routine test and it would show multiple abnormalities. Mostly there would be leukocytosis. LFTs will almost always be deranged, but not frankly so. Frankly, elevated ALT should suggest the possibility of primary hepatitis rather than pancreatitis. Kidney function must be done, renal function must be done, particularly creatinine, because this is one of the prognostic indicator. And of course, you would then monitor the patient for kidney function. So somebody presenting with normal creatinine, but later on creatinine rising would indicate a serious prognostic situation. Calcium phosphate, alkaline phosphatase should always be done at the time of presentation because this could constitute the etiology. But more importantly, in pancreatitis, calcium level may drop because of the phenomenon called saponification. So because of these enzymes, and calcium may precipitate into the tissues and serum calcium may drop. And drop in serum calcium can cause many problems, and one of them is seizures. So I think serum calcium must be done as a baseline and repeated also whenever considered appropriate. It is also one of the prognostic indicators. So that is why you need to do calcium in all patients with pancreatitis. CRP is expected to be elevated, chronic inflammatory state, that should be D dimers, because there could be secondary thrombosis, and also these veins, the portal vein thrombosis or mesenteric venous thrombosis, they also come in the differential diagnosis, so D dimer should also be done. Arterial blood gas analysis. So in fact, all patients who are serious or potentially serious, we do all these tests. A patient with acute pancreatitis is likely to be admitted in an intensive care setting, so arterial blood gases will also be done. This may show some acid-base abnormality and also secondary pulmonary complication. So I think this, of course, is a lengthy list of investigation and still not complete. There would be other tests which would be needed as and when required. Now, after blood tests, we also go for imaging. I'm spending some time on diagnosis, but since this is a serious condition, simultaneously we start the medication. So, but imaging is done to finally confirm the diagnosis. I think the best imaging technique, best in the sense because it is most readily available, literally on the bedside in all hospital settings. Abdominal ultrasound is our first investigation of choice. It can confirm swelling of pancreas and it can also confirm some of the complication. Now I'm going to show some of the images. Abdominal CT, in some cases for more anatomical details, you might like to do CT scan or MRI of abdomen. CT of course is cheaper, MRI is more sophisticated. Both may be done, or if you have the choice, maybe you should go for MRI. Then in some cases ERCP and MRCP may also be required. X-ray abdomen is a useful test. It would be, you will be able to detect if there is any chronic pancreatitis due to calcium deposits in the pancreas, and also if there is any paralytic ileus. And X-ray chest is done especially when you suspect pulmonary complication like pleural effusion, which is typically on the left side, or maybe pneumonias also. So I think all these investigations and some more are done as the condition demands. So now I'm going to show you some of the images which would be relevant. So this is the ultrasound. As I said, this is the first line of imaging investigation. This is the normal pancreas. Transverse view at the upper level of abdomen. Now this is actually the pancreas. This is the stomach tissue and abdominal wall. This is the pancreas. This is the pancreatic head, body, and tail on this side. And this is the splenic vein which passes behind the pancreas, and these are the all vessels. I think this is the superior mesenteric vein or portal vein. So these are the structure which you can identify, but I think most importantly, see this pancreas. Now compared to this one, this is the pancreatitis, perhaps not yet with too many complications. This is pancreas, all is swollen. The ultrasound texture of pancreas is altered and it is swollen. Of course, these images are to be interpreted with proper context. This is MRI, normal pancreas, and this is swollen pancreas with irregular outline and some necrosis. So this is pancreatitis. One of the complications of pancreatitis is the formation of what we call phlegmon. Phlegmon is a big mass of inflammation and necrosis. So this is the, look at this, this pancreatic tissue is transformed into big mass. Like I'm just moving my cursor around this big mass. This is aorta, the superior vena cava, and these structure kidney. So I think this is the big mass. This is stomach. This big mass is called phlegmon. Sometime patient may develop, usually in the subacute phase, with a week or 2 weeks after acute pancreatitis, they may develop a condition called pseudocyst, pseudopancreatic cyst. This is the cyst. Now, why do we call it pseudo? Because the true cyst is supposed to have a epithelial wall, but this one does not. It's just a collection of fluid, collection of necrotic fluid consisting of fluid and blood and inflammatory exudate. So this collection, which is not walled with epithelium, this is called pseudocyst. So this is one, and this is another one, seen large pseudocyst with a regional lymph node enlargement. Pseudocyst is one of the complications of pancreatitis. Mostly it is left alone to resolve, but in some time we have to treat it with surgical techniques or some endoscopic techniques. Now let's talk about the treatment. First of all is analgesia, because patient has basically presented with pain, so you need to choose right analgesia. These simple analgesics like paracetamol and non-steroidal anti-inflammatory drugs, they do not work very well in pancreatitis. Like in myocardial infarction, we use narcotics, nalbuphine or morphine. They are the types which we use. Tramadol or nalbuphine or pethidine or morphine, these analgesics are used. So of course intravenously, because this patient would have a lot of pain. We also give proton pump inhibitors as IV infusion, but basic analgesia is these drugs which I just mentioned. Patients are asked to stay NPO. NPO is none per oral cavity. So patient is instructed not to eat anything or drink anything. Why? Because any food intake is going to stimulate pancreas and is going to force pancreas to produce more enzymes, and that is going to further complicate the problem. And these patients are also likely to develop paralytic ileus. Again, food is going to complicate the thing. So in fact, patients are so much anorexic, you won't need to do a lot of effort to ask a patient not to eat or drink anything orally. In mild cases, patient can drink water or maybe plain liquids, but in severe, moderate to severe cases, it is best to ask patient not to take anything orally. In fact, sometimes we pass a nasogastric tube. Mild cases might not require it, but the severe cases, they need a nasogastric tube. The aim of passing a nasogastric tube is to remove gastric secretions and intestinal secretion, because we understand that removing these secretion can help the patient improve faster. Then if you are not giving anything orally, patient need something, the fluid requirement. So IV line should always be established. In fact, 2 IV lines should be established, because these patients would require a lot of fluid and also many medication intravenously. So IV line should be established, and fluid management, in fact fluid resuscitation, is one of the main treatment principles. When you manage fluid, you must keep an account that lot of fluid is also going into the retroperitoneum. So you need a very skillful approach. You are not replacing only the daily requirement fluid plus the outer output. You actually need to have some idea how much fluid is going into the third space, into the retroperitoneal space, and you have to make account for that also. So fluid replacement, very intelligent. I think after analgesia, fluid replacement is the most important thing which can lead to better outcomes. Shock management, unfortunately some patients, they would go into shock, so they would require shock management. So all these things require elaboration. I might not be able to go into the detail because lecture time would not allow that, but you know the principle of treatment of shock. There was a time when I think still some pancreatic enzyme inhibitors are available, but they are of no use. They never were shown to be effective because when patient comes with pancreatitis, most of the damage is already done, and naturally further production of enzyme is stopped. So that time giving an enzyme inhibitor would not would not be expected to lead to any improvements. So they're not very effective at all. Now this is a flow sheet. I'm sure if you're dealing with a potentially serious patient, you know what flow sheet is. Flow sheet is an organized way of keeping record. Since patient with pancreatitis has got lot of problems which can go wrong, which can develop. So you will make this flow sheet. You will make a chart and you will monitor all these things like pain severity, sensorium, bowel movement, blood pressure, heart rate, urine output, serum electrolytes, serum calcium particularly, pH, blood glucose, creatinine and more. So you will monitor them periodically and you will chart them down here. So then you will know if the calcium is going up or down, if the pH is going up or down, if the BP is dropping progressively, if the heart rate is going up and up. So with that you will have a very reasonable idea if the patient is improving or otherwise. So maintaining a flow sheet is extremely important. Some acute complication. There may be phlegmon formation. I've already elaborated on that. Abscess formation, if there is superadded bacterial infection, that could translate into abscess. That of course, patient would have high grade fever with rigors and chills, and you could isolate bacteria from the blood, and there may be gut perforation, very serious, paralytic ileus and gut perforation and ulceration, hemorrhage, and hypovolemic shock. Because a lot of fluid is going into the retroperitoneal space, and if you're not replacing enough fluid intravenously, patient may develop hypovolemia and could go into shock. Then pseudocyst formation, and then sepsis and endotoxemia. There could be bacterial infection and patient may go into endotoxic shock, which is even a bigger trouble. So a bigger trouble on the top of one trouble, it would make the condition very serious. Paralytic ileus is when the intestines stop moving. Sometimes there may be perforation, but otherwise they are just dilated. The movement is reduced, and this should be actually, they should resolve on its own if you are treating the patient well. These are some of the complications. This is the phlegmon. This is the left-sided pleural effusion. Now, pleural effusion could develop on either side or both sides, but typical pleural effusion of pancreatitis is on the left side. Reason is that pancreatic head from here, it mostly goes, the body and the tail is on the left side. So since it is the involvement of the neighboring pleura, so it is logical to understand that pleural effusion developing on the left side is more likely to be consistent with pancreatitis. Then this is X-ray abdomen showing paralytic ileus. You can see all gut loops are dilated and they're full of gas. So this is paralytic ileus. And this is an erect posture. You can see that there is no air here. If there is air under the diaphragm, that would indicate perforation. That might give you an alternate diagnosis of perforated peptic ulcer, or that might indicate that due to gut involvement, there is perforation of gut in pancreatitis. So either way, this would be a serious problem. Role of surgery is limited, but there are certain situations where surgery can help. Number one, removal of necrotic material. This phlegmon may cause a lot of toxemia, and necrostomy or debridement or removal of this necrotic tissue may actually lower the burden and patient may improve. cholecystectomy, because gallstones are responsible for pancreatitis, but timing of cholecystectomy vary. It is usually not done in the acute phase, but once patient recovers, and if you believe that gallstones are responsible for pancreatitis in the given patient, then I think cholecystectomy should be undertaken to prevent further attacks. Dilatation of ampulla of water with ERCP. If you suspect microlithiasis and patient got recurrent pancreatitis, or patient is suspected to have a CBD structure or stone stuck there, I think ERCP offers a very good technique to remove this. But again, mostly we would want patient to recover significantly before doing this procedure. But I believe this can be done in the emergency situation also, because it is much less invasive than cholecystectomy. Draining gastrostomy. If patient develops pseudocyst that is with an endoscopic procedure that is drained into the stomach. So this is the standard technique. Previously this used to be done with surgery, but nowadays it can be done endoscopically. Some chronic complications. Patient may develop chronic pancreatitis or chronic recurrent pancreatitis, chronic exocrine deficiency, and patient may develop malabsorption because exocrine function is affected. Patient may not produce sufficient amount of amylase and lipase and chymotrypsin and elastase, so patient might require supplementation with these enzymes. Patient might develop malabsorption like syndrome, bloating and diarrhea and nutrition deficiency, or patient may also develop sometimes chronic endocrine deficiency in the form of diabetes. Now, since in post-pancreatitis beta cells are destroyed, the whole pancreas is destroyed including beta cells, so there will be critical insulin deficiency. I believe these patients should be treated on the lines of type 1 diabetes. That means they would require insulin earlier on. So differential diagnosis, cholecystectomy is the cause of pancreatitis and also maybe the differential diagnosis. Acute cholecystitis may be the differential acid peptide disease. Typically these days acid peptide disease does not become that bad because we have very effective medication, but sometimes there may be erosive gastritis. Patient might have ingested something which has caused severe inflammation and erosion of gastric mucosa, and that could cause the pain similar to pain of pancreatitis. Acute myocardial infarction, of course we know it, that it can cause epigastric pain, but it should not cause tenderness in the epigastrium, and it should not cause other local signs. Dissecting aneurysm and many other conditions actually. So you need to keep all these possibilities in mind. Prognosis. It is a potentially serious condition and can lead to death. Despite our very good understanding of this disease, despite many treatment modalities available, medical treatment, surgical treatment, but still there are people with severe pancreatitis who may die because of this complication. And there are some long-term sequelae like malabsorption and diabetes and chronic pancreatitis, chronic recurrent pancreatitis. They are the long-term sequelae. Now, to determine prognosis, there are many algorithms. Now, this is the one most traditional and most well-validated Ranson's criteria for pancreatitis. We used to do it manually. There are many clinical and laboratory criteria, and we put them together and then do scoring, and then finally find out where on that scale from mild to moderate to severe to very severe patients stand and what mortality is expected. But luckily nowadays we have apps. If you scan this QR code, it will lead to that page and you can put in your values there and calculate the prognosis. Now it could vary. At the time of admission the number could be different, and after 2 days, 3 days, maybe it has gone worse or it got better. So I think you have to do this repeatedly. Summary: acute pancreatitis is an emergency and is associated with very significant morbidity and mortality. you need to keep a high index of suspicion to pick up these cases early. Intelligent treatment approach can save lives, and it could cause the cause could be determined, so the future attacks should be prevented, and in 40% cause remains elusive. So with that, I like to conclude my talk with the hope that you learned some new points, or some points you already knew, they were more emphasized and you got better understanding. So this has been Professor Aziz Rehman from Medurstand-Understanding Medicine. I really look forward to see you in my other lectures in the same series. Thank you.